Good afternoon again. The slides. Thank you. Yes, ocular surface surgeries, coming back to the surface from the anterior chamber, is probably required in many of the pediatric cases which we see in OPDs. So it might be required during an acute event or as a tectonic procedure or chronic sequelae to one of the problems that happens to the eye. Now most common diseases which we come across in kids are thermal or chemical injuries, then Stevens-Johnson's, a quite significant number of them, and VKCs. Though VKC is common, a condition which requires surgical intervention is not that common. So coming to chemical, in acute stage, the aim of intervention or surgical intervention here is to, or even medical management, is to control the inflammation, reduce the scarring response, and obtain as normal a healing response as possible. And you may have to, do multiple repeated procedures in this situation to achieve an optimal outcome. Look for any necrotic tissue in the acute stage, because these necrotic tissues incite inflammation, perpetuate it, and keeps on the inflammation going on. So that is the first thing to do in this. The next step is to look for the retained particles of the chemical. This is something which many of us forget to do or just avoid, because these children are in severe pain, very uncooperative. We try to retract the lids, they don't let, and they don't allow you, so probably we tend to take it lightly, start medical management and think, okay, we'll do something sometime later. But no, these are medical emergencies. This has to be examined at the first visit. If it is not possible to do them in the OPD, please take them to OT. Do it under general anesthesia. Make sure you see the whole eye surface and there is nothing in the eye. That is mandatory. Now once you have examined and found out a necrotic lesion or any chemical or particles, those have to come out. So if it is a very superficial burn, just debriding it with a cotton bud will peel off the tissue, cut out all the avascular tissues till there is a mild bleeding, and then cover the whole surface with amniotic membrane. What I usually do is I tag it on along the lid margin with a suture, then glue the rest of the amniotic membrane onto the eye surface so that it actually drapes from the lid margin, posterior surface of the lids, fornix, bulbar conjunctiva, cornea, then to the other side, and finally take the fornix suture so that the amniotic membrane stays well opposed to surface. This is another procedure. Tenonplasty is another procedure which is horribly under-recognized and very less utilized. When there is significant limbal ischemia, this actually helps. Now the question is, when should we do it? Should it be done at the first sitting, or immediately if the patient comes with severe ischemia, would you do it or not? Slightly controversial. What I generally do is I don't do tenonplasty on the first sitting. First sitting, if it is required, you do an amniotic membrane, do a thorough debridement and all, and see how the eye heals. In about 5 to 10 days, there will be revascularization and the exact area of dense ischemia is clearly delineated. That is the time when we really go in and do the tenonplasty. Now, if there is a frank perforation, tissue adhesive comes to the rescue. If there is a corneal melt, lamellar or penetrating keratoplasty, extensive melt, you may need to have a large therapeutic penetrating keratoplasty. In acute stage, the outcome of these procedures is not great, but then these are globe-saving procedures, and what we are concerned here is to save the globe and not to really restore the vision at this stage of the disease process. Now, in chronic stage, when there is a lot of scarring, simplifera, and all, the management decision or how you proceed is stage-wise. The first step here is to reconstruct the lid and the fornix. Like shown here, if there is a dense, adhesion, you release it, reform the fornix with amniotic membrane. We may even have to use a buccal mucous membrane to form the fornix and the lids properly. Once the ocular surface is well formed, then try to address the limbus. And finally, the corneal transplant. So the limbus, this used to be the algorithm of management. Conjunctival limbal graft, which can be either autograft from the other eye or from the live-related keratolimbal ex vivo culture. So again, before any sort of limbal reconstruction, the first step is to remove the whole pannus from the surface. This is actually an old video, and it is now very clearly shown in the literature that the combined corneal transplant with the limbal reconstruction is not a good way to go ahead. This is our autograph taken. You can either take 6 clockers from one side or 3. If it is a 6 clockers, you split it into 2 and put it on both sides and then secure it. Keratolimbal allografts, well, it's practically not practiced nowadays. But this is how you dissect the graft after punching the donor button fixed onto a prosthesis, and then do a dissection to get the the limbus. This is a PK done, and this is the limbal graft which is staying there. These videos are actually about 12 years old. I mean, most of us doesn't do this procedure anymore because of the problem is here you have to immunosuppress the patient systemically, and all the problems with immunosuppression, the expense, the complications, the compliance, all those issues are there. Then came the era of cultivated limbal epithelial cells. A small biopsy, about 2 to 3 millimeter of the limbal biopsy is taken. This is the limbus which is taken. Once the limbus is separated, it is chopped into multiple small pieces, put an amniotic membrane, and it's cultured so that you get a monolayer expand on the amniotic membrane. Then the second stage, you go to the a damaged eye. Again, the first step, like any procedure here, is to remove the pannus from the surface, and then the amniotic membrane with the cultured cells is gently placed onto the surface and secured either with sutures or, if whenever possible, with fibrin glue. About 70% success in 2 years. Then came the the simple limbal epithelial transplant, or SLET as has been named. The problem with CLET is it is expensive and time consuming. Expensive because you need a lab where you have to take the limbus and culture it, and time consuming because it's a 2-step procedure. First culture, then about 10-15 days once you get the culture, you do the other eye. In SLET, it's a single-step procedure. Actually, the eye acts as the lab for the transplant. The first step here is to remove the pannus, then harvest the limbus from the other eye, fix the amniotic membrane first, glue it nicely, then try take the limbal biopsy, cut it into multiple small pieces, spread it onto the surface in circular manner, try to avoid the central area, fix it with fibrin glue, put a bandage contact lens. Very simple procedure and highly successful. These are some of the pre and post pictures. Now the advantage here is it's especially useful in children. While the success rate in both CLET and SLET in adults is almost same, in children there is a huge difference in the success rate. CLET far superior to cultured cells. So CLET effectively restores the normal corneal structures, improves the visual acuity, works reliably well in children and adults, and better affordable alternatives. The next problem which we face is Stevens-Johnson syndrome, can be devastating. Acute stage. This is one stage where many of us ophthalmologists doesn't come across, and people who are in multi-specialty hospitals have the advantage of seeing these patients, and it is at this stage where we can make a real difference in the life of these patients. And it has been shown that amniotic membrane grafting at this stage has been able to prevent or mitigate the devastating and blinding complications of SJS that can occur in the chronic stage. Now, how it is done? it's not a very complicated surgical procedure at all. Remove any of the membranes or pseudomembranes on the surface. Again, like what I showed in the chemical injury video, the idea here is the whole eye from the lid margin to the lid margin has to be draped with the amniotic membrane. So once all the debris, the pseudomembrane, everything is peeled off, the amniotic membrane is placed and is secured to the lid margin with sutured. Then you can glue it onto the lids and the bulbar surface with the fibrin glue. After that, you can either take a Fornix forming suture. If it is difficult, you can in fact form a small ring with the IV tubing and push it into the Fornix so that it stretches and actually keeps the membrane apposed onto the Fornix. Such a simple procedure and actually can prevent development of these kind of complications later. The chronic stage, this is the culprit that causes most of the problems because of the mechanical and secondary inflammation. Again, in our setup, this is the buccal mucous membrane transplantation for the lid margin keratinization is the most effective one. Peel off the keratinized tissue from the lid margin. What is important here is care should be taken not to damage the tarsus. The mucosa is harvested. It is thinned out as much as possible. You don't need that bulky mucosa. You need a very thin layer of the mucosa here, secured to the lid margin with suture, trimmed to the defect size, and it is glued to the surface. Now this is, if you can see this eye, this is actually dry keratinized eye. This eye, patient is seeing, he has vision here, some moisture. This is after post MMG. So the rationale here is the mucosa provides a smooth surface which reduces the microtrauma and inflammation, which significantly improves the patient comfort, reduces the photophobia, and to a certain extent it improves the wetchability of the eye. So this is a very good article which is still in the press coming up, and they have actually shown how to manage chronic sequelae in children. And it is interesting to note that this is how they conclude. In children with chronic ocular sequelae, conservative therapy has got absolutely no role in the long-term treatment. It is a surgical condition where MMG in our setup, pros lenses are nothing other than scleral lenses, is very effective. The problem, or scleral lenses, the problem in our setup is it's highly expensive and very difficult for these patients to maintain them. Then comes the BKC. As you know, limbal form, you have the large papillae. The mainstay of treatment here is medical to get the inflammation under control. Surgically, you have to intervene when there is a shield ulcer. Grade 1 and grade 2 probably no, but then when there is an elevated plaque, you have to intervene surgically, peel off the plaque, and amniotic membrane does really help in healing them faster with minimal scarring. And when you have such large papillae, does a surgical intervention is really needed? It is needed when you have controlled the inflammation, but you fail to control the epitheliopathy. That is when you decide to intervene them surgically. Cryo is one of the way of doing it, but then that doesn't really help. Then excision alone doesn't help. There will be recurrence. Excision with amniotic membrane doesn't help. There will be recurrence. Excision with bulbar conjunctival transplantation also doesn't help. There will be recurrence. The only one which we have found to be of any use is buccal mucous membrane transplant. Excise it again. Lip mucosa, very thin layer, glue it onto the surface. It does prevent recurrence. In fact, if recurrence occurs, it occurs at the edges. It doesn't occur onto the area where you have transplanted. This is one useful technique in these cases. And in end-stage BKC, when there is limbal deficiency, it is usually bilateral. That is when you have to think about other options like alloslet. In these desperate situation, probably you have to think of doing this, because any allo transplant means systemic immunosuppression with its own problems. Then another controversial area is pediatric keratoprosthesis. Not a big fan of it. I believe, pediatric keratosis is a philosophical decision rather than a scientific decision, because keratoprostheses will have problems. So you have to decide whether you should be, the person taking the decision to induce those problems in these children's life. But then, yes, very selected cases there have been very good results. Like this is a failed graft for Peters, had undergone, Boston Capro type 1. So I think with that I'll stop now, and thank you once more, Rishi, for all the